I think we should be live, right? Let me check. Yes. Good morning, WebShadowers. Welcome to week 4. We would like to thank you all for attending our session this morning. Today, we have the pleasure of hosting Dr. Orajiaka, who is an emergency medicine pediatrician. As always, please remember that the Google form will be posted at the end in the comments. With that being said, Dr. Orajiaka, you may start whenever you'd like.
Okay. Hi, everyone. My name is Dr. Orajiaka, and like they said rightly, I am an emergency medicine pediatrician, which I will explain to you when the time comes. And I just wanted to say this again, the WebShadowers, you're doing an amazing job by getting this already. So welcome to the world of pediatrics. I'm not sure if you guys have had any experience with pediatrics before, or if you know anything about pediatrics emergency medicine, but we will get right into the conversation, and feel free to ask any questions and I will get that answered. So just a little bit about me. I am an international medical graduate. So what does that mean? I was born in Nigeria. I did my medical school in Nigeria also. And I migrated to the US to do, I migrated twice. First to do a master's in public health in Columbia University. And I practiced as a public health physician for a few years before coming back again to do my pediatrics residency. And then currently I am practicing emergency medicine, which I love. And then this is me in the emergency room. I have nothing to disclose. This lecture is not a representation of my employer. Some of the images are not mine. No patient information is divulged here, and this is just for education only. I am not diagnosing or treating anyone today. So let's talk a little bit about pediatrics emergency. How did I get here? So we will talk about what's the difference between pediatrics emergency medicine trained doctors and general emergency medicine pediatricians. What is pediatrics emergency medicine about? What are the things you always want to think about when you come to the pediatrics emergency room? And then we'll go through some case examples and then some Q&A just to get us started. So this is a path that you may take if you're thinking about pediatrics emergency medicine or a pediatrician. This one on the left is my path. Like I said before, if you have any international medical graduates or people from outside the country hoping to migrate to the US, this is what your path may look like. Maybe a little bit different from mine, but I went to medical school. And then after that, I did 1 year of master's in public health and then practiced a public health physician for a few years. At the same time, did clinical medicine. I still saw patients in Nigeria. And then I also did my USMLE steps at the same time. I did all that, matched into a program in the US, and I did 3 years to be pediatrics residency. So after your 3 years of pediatric residency, technically you are a you're a board certified pediatrician if you take the exams, or you're board eligible before you take your board exams. So this is where I am. Some other people, you can go ahead and do another 3 years of pediatrics emergency medicine fellowship, and that makes you a pediatrics emergency medicine specialist. That's a PAM. So I am a pediatrician who's still in emergency medicine setting. If you're a US graduate, this may be your path too. So you do your usual college, 4 years of medical school, 3 years of pediatric residency or emergency medicine residency, and then you also do the 3 years of emergency medicine fellowship to be a PEM doctor. So if you're down this path, I wish you luck. So what are your thoughts? So this is where if you have any comments at this point, I can take them. If you hear pediatrics emergency medicine, what comes to your mind? What are you thinking? And I know there is a little bit of a lag. I would just give you a few seconds to see if you guys have any responses. Okay. So I can continue while I'm waiting for those thoughts to come in. So I guess when you think about emergency, you're always thinking codes, is an alert, probably doing cardiopulmonary resuscitation in someone. Let me see, someone said, okay, exactly. Yes, you deal with both the patients and the sick kids. It is stressful, but fun. Children, toddlers, when they get into an injury, exactly. We deal with a lot of injuries. Concerned parents, perfect. You guys know it. Okay, so you already have an idea that it's not just the resuscitations, it's not just the alerts and everything happened. There's whole more than that. Treating ill children, exactly. Um, So yes, in the emergency room, just most of the things you guys talked about, there is a wide range of medical problems. We have the acutely ill and injured, just like some of you mentioned. We have the stable kids and unwell, but we also have the well kids who are just smiling that the parents are really concerned, who needs just a lot of reassurance. That's why I have the pictures here for you, just to give you an idea of some of the things you might see. We also have a wide range age. So we can go from a baby who is born immediately, maybe an outside birth, because typically they're born at the hospital. They tend to go what we call the NICU, the neonatal intensive unit. But for babies who are born outside and need emergency care, they come to the emergency room. We deal with that to the young adults. And sometimes we also deal with new adults who maybe they come in to visit someone in the hospital and they accidentally pass out or have a medical problem, they end up needing care too. So what we do in emergency room is to stabilize them enough before they can get transferred. So I like how you guys mentioned about treating ill children, concerned parents. So we're not interacting only with the child, we're also interacting with a whole lot of people. So when you hear emergency medicine, I want you to think more than just seeing a patient and stabilizing a patient. So this circle has a little bit about some of the things we do. Of course, the most important one is we diagnose, stabilize, and manage patients, but we also interact and consult specialties because emergency medicine is more like one bucket where we have everyone come, but then we have a cardiology patient who needs cardiology care. So after we stabilize them, we have to ask the specialist, what else do we have to do? So we have that advantage of interacting, also learning from the specialty. So that gives you a wide range of knowledge for that. Of course, we ease a whole lot of families from the anxiety. It may be a concerned parent, it may be a parent who actually has a sick child that you need to calm down while you're managing the family. But we also do a lot of advocacy and reporting, which means this is where we have some child abuse or sexual abuse coming in that they may be coming in with the reports, or you may find that out during your history and examination, and you have to advocate for those patients. Make sure you're doing reports to children's services and interacting with the social work. And of course, we do a whole lot of research and education to make sure we're continuing to improve the specialty. So this is like a good idea of what we do. So just wanted to show you a few pictures of what you can see. So you can see the good, a kid who just needs a high five and bye, maybe a hug, and they're good. Or you might see a child who maybe has a foreign body off his nose and up his nose, or maybe a little bit of a small boo-boo that needs cleaning, so they're not so good. Or you have a child who swallowed a penny, who thinks that's a way to get rich, that you need to actually take out. Or you have a broken bone that needs to be fixed. So not that bad, but these are the bad. But you can also have the really ugly. So these are the traumas, the intubation, the critically ill patients that need a lot of management. And I'm not calling them ugly because of physical appearance, but these are the really cases that we're worried about, that are thin line between life and death, struggling for survival. So now that we've known what, just a general overview, when you come, I want to talk to you guys about how to think in the PEDS ED. So when you're coming for a rotation or someone tells you PEDS ED, yes, there's so many things we see, but in the ED, it's all about prioritizing. who do you want to see first? This is not the clinic that we see patients based on first come, first served basis. If you do that, you're probably going to lose a lot of kids, or a lot of kids who come in stable may deteriorate or crash, as we call it, and get much sicker. So you always want to see the sick kids first. And there is a triage system, what we call the ESI, or Emergency Severity Index score, that helps us decide who to see first. And hold on, I'm just gonna move this to the side. So this is an algorithm that most of the time the nurses use this to help navigate where to put a patient, who is a trauma 1, who is a trauma 2, who is a patient that needs to go to the critical care immediately and have all hands on deck. So this is the algorithm that helps you make sure we're saving those lives well, and then we're also triaging those that might be able to sit a little bit more and get seen at some point. So you see that in 1, these are patients that need immediate life-saving intervention. So automatically they're what we call ESI level 1, and then 2, and all the others here, depending on what they need. So it's all about prioritizing. So you're making sure you're seeing patients right. And then now, so you've seen the patient right, what do you do first? You don't necessarily have to walk in and start asking, what did you eat yesterday? What happened to you? Did you play well? No, you always have to think about, I need to make sure this child is stable. Does this child need to be resuscitated? Do I need to save this life before I go ahead and ask who's your grandparents? Some history is necessary, but not, you always want to make sure you're doing the right thing at the right time. So we talk about resuscitation and stabilizing. And of course, we always have to do what we call the pediatric advanced life support, which would be a completely different class on its own. And when you're talking about resuscitation, I want you to think about in terms of circulation, airway, and breathing. So does this patient have enough blood going through the body? Are they in shock? Are they breathing? Is there something blocking the airway? So these are things you want to think about in pediatrics ED. And of course, diagnose, because you want to make sure the patient is stable before you start diagnosing, teasing out what this is this. Although the diagnosis is weaved into the care, a patient has to be stable and alive before you start deciding what your differentials are. So this is just a little bit of a snapshot of the PALS that I talked about. We will not dive into this, but it's the same impression. Is a patient conscious? Is a patient breathing? Are they responding? So always gives you an idea of what path to take, when to do CPR. I mean, this would be on the internet, so you can always go back and make a reference. I would just wanted to include it there for PALS. And then now that we decided what patient to see in the ED, how to still think about the ED. So you always want to think about how old is the patient you're going to see. You would not be thinking about, what do they call it? Cardiac arrest, or no, you would think about cardiac arrest, but you wouldn't think about the history of smoking in a newborn. That sounds a little bit off, right? So you always want to think about how old is this patient? How sick is the patient? What is most likely to be going on? Would you think it's a 2-day-old swallowed a penny? Not likely. They're not picking up things at that point. So you're not thinking about swallowed foreign body. So what do you do right now? So like I said before, always prioritize. What do you do right now? What do you do afterwards? And then who do I call when I'm done managing this patient? So consults, I mean, when you start taking exams, consults are always things that always pop up in exams, but consulting specialties are never the first thing you do in the ED scenarios. You always want to specialize, come up with a plan before you call a specialty. And then disposition. So now you're all settled. The patient needs to be admitted or the patient needs to go home. ED is not a place that people get admitted in. So you always have to have a disposition, which is like an admission versus discharge plan for a patient. And then when we get down to looking at a patient, I want you guys to have these at the back of your mind, because we're going to look at this for all the cases we will go through. Examinations, what do their vital signs look like? Children, some children don't talk to you, like you deal with numbers and what they look like. So in pediatrics, you have to use your eyes a lot. Eyes to look at the numbers, eyes to look at what the kids look like, eyes and hands to examine them, and it needs a little bit of technique and detail. So that's what that's a little bit how pediatrics is different from adults. But adults might tell you my belly hurts, but in a child you might see they're in pain by what their vital signs looks like. So those are just a little bit of things I want you to think about while we go through the cases. And of course, before you use your eyes and your hands, if you don't know what normal is, you would not know what's abnormal. But that really comes with experience. You will know what the normal vitals look like if you already know, if you know what abnormal, oh, hold on, let me go back a little bit. What abnormal looks like if you know what the normal vitals are. You will know what the normal neuro examination looks like if you know what the normal is. And this, and of course, skin colors. Sometimes it's difficult to know a child is in shock if they have a darker skin, but with experience, you should be able to tell the differences. So always know what the normal is in pediatrics so you can tell what the difference is with a normal child. And I added this slide. I'm not sure if you guys can see this picture clearly. There is a chart that helps you tell, gives you an idea of what the normal child vital is. What is a normal heart rate? What is a normal blood pressure? So that if anything goes wrong and you're not sure, or maybe when you're doing the early stages of your training, you can look at it and say, hey, this child is 14 years, but already has a heart rate of 160. That seems off, and I need to investigate more. And then you think about investigating. Okay. Okay. So before we narrow it down to one of the main thing that I want to talk about today, do we have any questions, comments, takers? And I will be because we have wide range of ages, wide range of specialties, I decided to just choose one, pediatric abdominal emergencies, give a few cases, go through a few, and just give you an idea of how to get a history, what you can see, and how to manage a patient. And some of them may be similar, but it just to give us a thought of what do we do, what do we think about, and just to give you a start before we continue you continue a path in pre-med and maybe medical school at some point. Do you have any questions yet? Okay. And while that is coming in, so I know I said a lot about prioritizing. Let's see how is the mental state of workers in the ED. Okay, I will have you hang that thought and I will discuss that towards the end. Don't forget to ask me that question again. I want us to be able to get through this. I will definitely answer that. How do you think passes in medical? Okay, I will answer that later too. That kind of helps you, that masters in public helps you have a broader thought that you're not managing only the patient, you're managing the community and where they're coming from. Because the child coming in with an abuse, you want to ask what's happening outside. I take care of your fractures, but what's happening? So it just kind of gives you a wide range of thoughts. What do you do if you can't reach a diagnosis immediately? So first, if the patient is stable, there's some patients that definitely take a long time to decide what's happening. You may have to do more evaluation. Might mean more ultrasounds, might mean more blood work, might mean more imaging, ultrasound, labs, trial, lumbar puncture. You just have to keep trying. There's so many things that there's so many patients that actually get admitted for days trying to reach a diagnosis. As long as they're stable from an emergency medicine point of view, they can be admitted. When did you realize, okay, I'll talk about that later. What surgical procedures you perform in as an EMP's doctor? So you can do suture and you can do incision and drainage. You can also, depends on the location you're practicing, you can do things like intubations. You can also do things like chest tube insertions. You can do things like reduction of fractures. It just depends on where you're practicing, the institution you're practicing. So like a pretty wide range of that. Okay, so how do you help treat children with mental and physical disability? So that's a really tough group of patients that you end up, one, you still need to look at the numbers. Two, you may have to do like a more detailed examination. And we always recommend examining them in the comfort position in terms of on their appearance when they are calm, so you can feel the abdominal area well, you can touch the bones well. But then also these are the patients that may end up needing more evaluation, like more lab work. more imaging, because you're not sure what's coming from where. You just want to make sure you're finding where exactly this child is uncomfortable. But this is a really good question. That's a challenging group of patients, but it requires more evaluation. Do you think the critical thinking diagnosis aspect, social aspect? I think the social aspect is one that people tend to forget, because you get more trained in clinical aspect that you may forget the social aspect, and it depends on the case too. The child abuse and the sexual cases are more mentally challenging to me, but especially when they occur a lot. So I would take more. Seems like a lot of questions are coming in, but I would take more questions later. So tell me which of these patients you will see first, because we already talked about prioritizing. So you have a 7-week-old male with persistent vomiting for 2 days. You have an 18-month-old female who's coming in with intermittent abdominal pain. You have a teenage female with fever. Tactile fever means they can feel the body feels warm, but they never check the temperature. With tactile fever, abdominal pain, and vomiting. And you have a 7-year-old male with bicycle injury to the abdomen with persistent vomiting. So who do you want to see first, based on just a little bit about what we discussed about prioritizing? 4. Okay, good. I hope you have a reason why. 1, good. One, as being very young with persistent vomiting. Okay, I like it. I was going to say 4, but then I realized 1 is very young, persistent vomiting, 6 constant regenerate. Perfect. Okay. I like a lot of all the ideas you guys have. So you're thinking about prioritizing already. And so you guys are not wrong, but it depends, right? It depends on what the patient looks like. What do the numbers look like too? So you have the 7-year-old with abdominal injury. You may look at the numbers and the blood pressure is pretty low, but then you look at the 7-week-old and the vitals look pretty good. Not that you don't need to see them both, but the 7-year-old sounds more like an emergency. Or maybe the reverse case too, right? The 7-year-old might look more stable, in pain, but then the 7-week-old is not mentally alert, not waking up when you go and examine them. So that means you have to see 1. So it totally depends, but definitely between 1 of them first. So let's talk about some cases. So the first case, and this is I'm not going to go through them in any particular order of how critical they are. I'm just going to go through by age, but I left number 4 for last because I want you guys to get more involved with that too. So we have a 7-week-old cute male who's presenting with 1 week of spit ups. Spit ups means they feed and they have some milk come out. This is not a baby that had any issues with like spitting up in the past, but mom tells you they're coming in now and they're spitting up a little bit. But now for the past 2 days, they've had non-bilious and non-bloody projectile vomiting. Non-bilious means there's no bile in what they vomit, but the baby still feels hungry every time mom is done, when they're done with the vomiting, so mom keeps feeding. And mom tells you they looked good before, but now they seem to be appearing more tired. Do you guys think anything yet? Okay, I know you guys are thinking, but I'll just continue in the interest of time. So always ask, there's something called review of systems. So now that you have the baseline history that mom tells you about, you want to ask more questions so you can decide, is this related to infection? Is this related to trauma? Is this something more like an organic or structural issue with the intestine, the feeding system? So now you want to ask more questions. So now, of course, we will get to vitals, perfect, but let's ask more questions first. Of course, you would have looked, so I like the check the vitals. You would have looked at the vitals before you go see this patient, because that helps you decide, is this kid sick enough for me to go asking other questions, or do I need stabilization? So whoever said check vitals, that is perfect. So in the history, you want to know what are the feeding patterns, how much and how frequent. You want to make sure that the mom is not overfeeding this child. So if they're telling you the child is getting 10 ounces every hour, it may be a little bit too much of food. So those are things to think about. You want to know how many wet diapers is this child having? Are they getting dehydrated when the wet diapers start going down? When was the last time they pooped? Children that have a possibility of a high risk, of not high risk, a high probability of obstruction tend not to continue having stools. So you want to know, when was the last time this child had a bowel movement? Any fevers, any diarrhea, any upper respiratory infection symptoms, because you're thinking about infection now. Any rashes, any sick contacts, because if a child has a family member with persistent vomiting, so which means there might be something going on in the house, right? In children, especially ones, so most people say when they're less than 2, but others say infants, which is less than 1, you always want to get a pregnancy and birth history, because it might be something related to birth, which is manifesting later in life. So you want to know, what's the pregnancy? Was mom with any infections, any medical problems mom has? So this mom had just diabetes, but otherwise had no significant pregnancy history. And this baby was an ex-full-term male who had no NICU stay, so did not need to go to neonatal ICU and weighed 7 pounds at birth. And they tell you baby cried immediately, meaning they didn't need any resuscitation, and also passed meconium after discharge. So meconium, if the first poop that children have, babies have when they are born, and it's dark. And we expect them to have this meconium before the first 48 hours of delivery, because it helps us think about something called Hirschsprungs, which you guys can go check out. It's not like a topic of discussion for today, but we always want to have children to have the first poop before they get discharged. So let's talk about general appearance. So look at the vitals. Let me know if anything jumps out, or anything you guys are concerned about. I'm not sure you can see what the normal is, but the child's temperature was 98.3, so does not have a fever. The heart rate is 180. The blood pressure is 66/40, and the respiratory rate is 35 when the child is calm. So the heart rate is, you might look at it as high, also depends on if the baby is crying or not, but the heart rate is between 85 to 205. It's still within range for child this age. So a little bit high, but not that striking. So general appearance, what does this child look like to me? So the child has decreased activity, just laying on mom, but aggressively sucking on the pacifier. Good heart rate. I like that. So aggressively sucking on the pacifier. Remember, they are hungry vomiters. So they vomited, but then they are still hungry. So dry lips and mucosal surface, sunken eyes. So this is even before you touch the child. This is what you're seeing already, telling you that this child may be a little bit dry, right? And then you look at focal examination. So anterior fontanelles are open between birth and 18 months. Sometimes some close as early as 12 months of age. This is a place where you can examine if a child is dehydrated or not, especially in children this age, because it becomes sunken, because they're losing fluids, they're dry. So the anterior fontanelle, I should have put a picture, is that place on the top of the head appears sunken. So this baby's was a little bit sunken, and the abdomen, you examine the abdomen, and all of a sudden you feel like this mass, a palpable mass on the right upper quadrant while they're sleeping. So this kind of gives it away. Do you guys have any thoughts on what's happening? And then, of course, you always want to do a full examination. Look at the lungs. Look at the rectal area too, because I've had scenarios whereby children come in with vomiting and realize that the rectum is not in the right place. There's a form of abnormality, and that's what you can always find out when you look. So always take a look. Heart rate is not supposed to be as high when they are sleeping. It's supposed to be lower when they are sleeping. It goes high when they have a fever, when they are comfortable in pain, or when they are asleep, or when they are screaming and crying because you're examining them. So what are your differentials? I will give you guys a few minutes to talk about that. What's coming to your minds? Maybe like a few seconds, so we're meeting up. Okay, gallbladder. It's not IV line. Okay, we will get there. Liver, okay. So I want to say it's right upper, but it's more mid right upper. I see I kind of twisted and moved you guys all to the right side. Gallbladder, gallstones, possibly. So think more midline. Pyloric stenosis. Perfect. Look at that. Okay. So these are things to think about. Pyloric stenosis, of course, reflux, overfeeding, like I mentioned before. If a child is being fed more than they can take, they will definitely give it back to you. Gastroenteritis, but you expect them to have some form of diarrhea at the same time. Formula intolerance, possibly, but then the vomiting is a little bit excessive. Of course, in this age, COVID-19, because kids have different manifestations. Inguinal hernias, it's a form of obstruction that keep having kids to vomit. Testicular torsion, especially being a male, it may manifest as vomiting too. And you guys have really great answers too. So what would you do next? So this question, it depends on where you are, right? Because it depends on what kind of institution and what you have available to you. Based on this history and what I'm thinking already, I'm palpating something in the upper quadrant. Based on the vitals, this child still looks stable. I would consider an IV line, but I want to get the diagnosis for the patient. So since I have ultrasound available in my facility, I always send the kid to ultrasound immediately. So that way we can know what's happening and get things started. Of course, IV and labs, because you're worried about if the baby is vomiting as much as that. One, you want to make sure they're not hypoglycemic, which means their blood sugar is not too low. So you can actually do what we call a point of care glucose testing beside the bed to see what the glucose is. And then obtain other labs, because when you vomit a lot, you're losing a lot of electrolytes. So you always want to grab that. So yes, the answer was pyloric stenosis. So just a little bit of an anatomy. This is this is the baby, this is your feeding tube, and this is your stomach. And between the stomach and what we call the duodenum, this a part of the small intestine, there is this sphincter, which is called the pylorus. This is not supposed to be this thick, but in pyloric stenosis, it is pretty thick and it builds over time. So what happens is it becomes too thick that it closes off. So everything the baby feeds comes down here and it comes out immediately. And that's why we call it projectile, because the force it comes out with, mom tells you, is shooting across the room. Always think about pyloric stenosis. And ultrasound is what you use to diagnose it. And if you're good with ultrasound, you may be able to understand this, but I want you to stick with me here. Look at the line. So there's some criteria used to diagnose this. It tells you that the length is longer because it's thick and stretched, but also it's thicker because you can see the thickness here. So you see the thickness is greater than or equal to 0.3 centimeters, or it's longer than 1.5. And you can see that this child meets the criteria for that. So just to give you a few fact or snippets about pyloric stenosis, it's more common in firstborn male. It has a higher male to female predominance for that. And we're not sure what causes it exactly. It's considered multifactorial, something related to genetics, because twins may have it together. A child of a male, of a parent that may, a male parent that had it may have it too. But also studies have shown maternal smoking may predispose you to that. And also a medication called erythromycin may also predispose you to that. And the classic presentation to tell you is it's gradual onset of worsening non-bilious vomit. And I will show you what I mean by the non-bilious. So it means the mom tells you wasn't vomiting before, now vomits more. Typically happens between the age of 2 to 7 weeks, rarely occurs after 3 months. So if you have a child coming in with similar history, think about something else. They are hungry vomiters. They may have signs of dehydration. You may observe a visible peristalsis. So it's right upper, but it's more like midline because the stomach goes this way. So you tend to palpate it around this area. And of course, you may do blood work and you will be noticing that your chloride is low. So this would be a different discussion too. But when a child is vomiting, what happens is you're losing a lot of stomach acid. And your acid in chemistry is composed of hydrogen and chloride. So the more you vomit, the more you're losing chloride. So your chloride level in the body is low, but then your bicarbonate is higher. So that's why you have this finding on electrolytes. You can start getting your questions ready and then when we get to the end. So diagnosis, get a good history, get a good examination, but the ultrasound is the imaging of choice. It's about 95% sensitive and it does a really job with diagnosing this. So how do you manage this? of course, stabilize the patient. If they're already vomiting, you want to tell mom, stop feeding, let's find out what's going on. You want to make sure you're checking the blood glucose and checking the chemistry, because if the child is hypoglycemic, the blood sugar is low, you want to make sure that you're correcting the blood sugar. For the child like ours that is slightly dehydrated, may consider a bolus, which is what we give. It's normal saline fluid, because you want to start getting them rehydrated. And of course, correct any electrolyte abnormalities you're having. And like we also said, you consult surgery. This kid needs to go to surgery because they need to release that thickening, and it's definitely done in the surgical room. But also, where this patient goes to in terms of disposition depends on what do they look like. Do they look sick to go to the ICU, or do they look stable enough to go to the floor? So that's how you think end to end for this patient. And this is just what the labs look like. I should have put the normals here. So typically the chloride is supposed to be about, it depends on your place too, it's supposed to be more than 100. So 90 is pretty low. And this is supposed to be less than 25. Why did you choose to do an ultrasound over an IV? So it depends on how stable the patient is. If you think the child is pretty dehydrated, or the child is pretty sick, you can go ahead and put in an IV. But if you think your institution is quick, we get an ultrasound too. You can get an ultrasound in a stable patient while the results are coming back, then you get the IV. Because then by the time you're placed, sometimes it takes the nurses or the doctors to get the IV done. By the time you're placing the IV, the ultrasound result is out, and then you're consulting your specialties at the same time. So it's just about what the flow is in your institution. What causes the pylorus to become thick? So that's the same thing we talked about. It's the muscle that's thick, because around that place has a sphincter, but then has muscles around it. We're not sure what causes that to happen over time. They just think it's a predisposition. It's a genetic predisposition versus environmental causes, but the real etiology, we're not sure what that is. Do you have any other questions about this before we go to the next case? Okay, I can go to the next case. And if you have any questions about how this patient is managed or what you would have wanted to do differently, let me know. So the next case is, so this is an 18-month-old, previously healthy female who looks relatively well while they come into the ED. So mom comes in because they're having 12 hours of intermittent episodes of abdominal pain. And mom describes it as, my child lays down, draws her legs up in discomfort. Can't really tell how long it lasts. We said in between episodes, maybe has about 10 to 15 minutes of no pain and continues to run around, but then has noticed that over time is getting more tired now in between the episodes and getting more sleepy. Do you have any thoughts yet? Anything you're thinking about? Okay, so review of systems like you always have to do to get more history. Mom told you had a few loose stools before this whole the episodes started happening. Is this a chronic issue? No, it's not. Once it's surgically repaired, pyloric stenosis rarely recurs, so it's treated once and for all. And back to case 2. Child had no vomiting, no fevers, no rashes, denies any history of hard stools, and said over the past, 5 days ago, had an episode of upper respiratory infection and has had no past surgeries. So you have a child who has intermittent abdominal pain, no fevers, no vomiting, no rashes, and has intermittent pain. Anything comes to mind? Okay, let's keep going. So you take a look at the vitals first, as always, before you even go into the room if you can. The temperature is 99.1. You have a heart rate of 120. You have a respiratory rate of 32 and the blood pressure of 100/56. So what's your general appearance? You go in, child is non-toxic, just kind of laying on mom, looks a little bit tired, but well hydrated. So when you looking at hydration in different ages, so this child may still have the anterior fontanel opening, but may have a lot of hair now for you to be able to tell if it's sunken or not. So you're looking at the mucous membranes, not just the lips, because dry might be my lips might be dry, but you're looking at the mucous membranes inside the mouth. You're taking a look at the cap refill, which is best examined at the tip of the fingers or the nails, and you're looking for tears, because now you're expecting the baby to cry with tears. And if they're crying for like minutes with no tear, then you may start getting concerned about dehydration. So focal exam. So on the abdomen, there's nothing, you don't palpate anything. Child does not seem to be uncomfortable, seems relatively well. But in between your exam, the child starts having the same episode of bending over and screaming. And of course, you get all the other examination done. Always remember to look at the rectal area, anal area, mostly in kids that have abdominal pain, constipation issues, but in most children too. Of course, when they get older, they're not as comfortable with it if it's not related to why they're coming into the ED, but have a habit of doing a full exam in children, because you may never know what you find since they don't always talk to you. Oh, I feel like I kind of give the differentials away. So some differentials. Which one do you guys think it is at this point? Intussusception, constipation, mesenteric adenitis, appendicitis, gastroenteritis, urinary tract infections. Any takers? Intussusception, perfect. Anything else? Appendicitis, good. Anything else? Okay. So before you know what the diagnosis is, I like that you guys already have your differentials there. So how would you know what it is? Depends on your institution too. Some places have may not have constipation, of course, may not have all the imaging capabilities. So it depends on what you have available. You can decide to do an X-ray. You can decide to do an ultrasound. But these are one of the cases that there is no straight answer. It depends on what you have. You may not necessarily be thinking intussusception first. You might be thinking more constipation. So here you want to get an ultrasound or an X-ray based on what you have. Of course, if you have no imaging capabilities in your hospital, you can consider IVO labs. But this patient is not vomiting, so there's nothing you're looking for in the IVO labs at this time. So you may want to skip that for now. So yes, we get an ultrasound. If you haven't seen an ultrasound or X-ray of intussusception before, this is what it looks like. So an X-ray of intussusception just shows you this is the right quadrant. I will get to the anatomy after this. So this is the right quadrant, right lower quadrant. You don't see anything here. There's no air here, but you notice that all the structures, there's a higher density here because the intestine here is pushed into the one above. So you notice that everything is on top. And of course, when you take a look at the ultrasound, you're seeing what looks like a target. So this is what we call a target sign, because there are two circles. It's like a donut. You're seeing intestines inside another one. So when you slice it, it looks like a donut. So this is what a typical finding in ultrasound, in intussusception. So of course, since most of you already know what this is essentially your child with an intestine, and you have one going inside the other one. So this is what I mentioned about when you slice it, you see that circle that looks like a donut. Again, it's more frequent in infants. Typically, 90% of patients are less than 3 years of age, and more male predominance than the other. Also, unclear hypothesis, but usually follows more after a viral illness. When you have viruses, when kids have viruses, some of their lymph nodes and lymphoid tissue get a little bit bigger. So the one around that intestine area, if it gets bigger, it makes it bulkier, and it's more likely to telescope and get into the other one. So that's one of the reasons why it happens. But also you can have it in older kids. And this is not the typical presentation, but older kids, older than 6 or 7, but you start getting worried about masses in that area, because then you might have what we call like a polyp or a tumor, which is making that area more bulky, and it keeps telescoping into the next one. So your classic, your typical patient would be an infant with intermittent abdominal pain, becomes normal or tired in between episodes. And I know there's this triad that we always talk about: abdominal colic with the mass, vomiting, and red color jellied stools. This is seen in only 20%. So if you're waiting to see this in your patients to make a diagnosis, it will be a late sign, because this red color jelly stool only happens when the intussusception has been there for a long time, causing obstruction, impacting or impairing the blood supply in that area. So it's more like a sloughing off stool. You start seeing dark stools, dark blood in the stool, because the intestines are sloughing off already. So you do not always see this. And of course, and like I said before, children don't talk to you. And in children that are less than 1, or like infants, you may just notice abnormal behavior because they're not having obvious belly pain. You notice them being very tired and having abnormal behaviors. Okay, so management, you guys already know the drill. Vomiting, make sure they have NPO, means nil per hour, nothing to eat. Check the blood glucose and blood chemistry, give them a bolus, and of course you consult. So this is one of the cases that you can actually manage with just the radiologist, because the radiologists are the ones in most facilities are the ones that do the reduction using an enema. And this just means they insert a tube from the rectal area, and what they do is they pump either air or barium or like saline through the rectal area, and it pushes the other. This is what it looks like. And it pushes the other intestine out of the other. The reason why you have to do a surgery consult is in scenarios where this cannot be reduced, then this patient might need surgery if they've tried once or twice. In some institutions, they say they're only comfortable trying once, but studies have shown that you can actually try 2 or 3 times, but make sure you're given a break in between. And of course, an emergency medicine physician, you may not necessarily be the one doing this, but your part is to make sure this patient has an IV, because sometimes they may go hypotensive during the procedure. You want to make sure they're comfortable and not in pain. So you're doing the IV and the fluids and the pain control. And depending on how it happens, if the child gets reduced, they may tolerate oral intake and make it home. Or if they're not able to get reduced, that's where surgery comes in, because someone mentioned, I think they will need surgery. So if the patient is not getting reduced, they go surgery. Do you do surgery in this patient using the same techniques as adults? I'm not sure what technique you mean. Technically, they get what we call laparoscopy, and they go in and they reduce it. So I'm not sure what the technique is you were asking about in adults. Do you need, okay. Any questions? I think I may continue going, and then I'll take the questions as they come, okay? And the third case is, so now we have a teenager. So you have to think older things. So we have a 14-year-old female with a past history of recurrent urinary tract infections and polycystic ovarian syndrome, who is presenting with a right lower quadrant abdominal pain, which continues to get worse over the 12 hours. Has nausea with multiple episodes of non-bilious, non-bloody vomiting, has felt warm but has documented no fevers. If you have any thoughts about this case or your differentials, this is when to bring that up, but I'll continue going in the interest of time. So review of systems as always. Any penile urination, patient tells you no. Any vaginal discharge, patient tells you no. Now you're trying to narrow down your differentials. Any bowel movement, can intussusception develop complication? Definitely. So with intussusceptions, one, if they've been obstructed for a long time, they can actually rupture and cause what we call peritoneal symptoms. Because now the intestines have been impacted for a long time. They start degrading, then they can rupture, and then you can have fluid going into your belly and your abdomen and making the child sicker. So definitely, there can also be cases of adhesions if they are not reduced early enough. So definitely can have complications. So our teenage patients, like always, all teenage patients, you always have to obtain sexual history, and if they're stable enough, what we call the HEDS exam, which you can definitely go check up. So sexual history is important because you want to know if it's related to a sexually transmitted infection, if it's related to pregnancy. So our patient has had unprotected sexual activity with 2 partners in the last 6 months, and has had the last one was 2 weeks ago. And of course, like I mentioned, HEDS assessment, any drugs, any sadness, any suicidality, because you might be the only way you may find it in the child will be when they're already in the ED. So you want to make sure you're asking that. Do we have any differentials yet? Okay, I'll keep going. So you're examining your patient and you take a look at the vitals. Let me know if you think anything is wrong with the vitals, and I can always see that as you respond. So she is 99.1 temperature, heart rate is 112, respiratory rate is 32, and her blood pressure is 140/90. She's obese with hirsutism, which means a male hair pattern. She's alert and appears uncomfortable in pain, and she refuses to move. You're doing your focal examination, and she's obese, she's guarding, she has tenderness on the right lower quadrant, and you feel a mass. By the way, I like the answers that are coming in. STI screening, pregnancy test, definitely. HPV, not really an emergency unless it's a different way HPV presents that you want to talk to me about. Blood pressure, what about the blood pressure? Blood pressure is a little bit on the high side. Remember, she's in pain, and children or even adults, when they're in pain, their heart rate might go up, their blood pressure might go up. Perfect. I like, unless she's pregnant. I like it. So it may be that, it may be also a component of pain. Ovarian cyst, I like it coming in. So no severe tenderness. So severe is when you're checking for pain related to kidney related issues, and that's in the back area. And then of course also your genital exam, you want to make sure you're looking for that. So other differentials we're having: ovarian cyst, STI, pregnancy, possible uterus condition, appendicitis, of course, it's the right lower quadrant, so never forget appendicitis. So differentials, ovarian cyst, fibroids. Okay, fibroids is not very typical in a 14-year-old who just started menstruating, or but you don't want to miss that too. And of course, I forgot the last menstrual period. You always want to get that in a history. Menstrual periods and menstrual history is always important in a female. Ectopic pregnancy due to high fever, pain in abdominal. Perfect. You guys have really good ideas. So let's see. Pregnancy, ectopic pregnancy, appendicitis, ovarian torsion, ruptured ovarian cyst, UTI, nephroUTI, which is like renal kidney stones, PID, which means pelvic inflammatory disease, and cancer. Good. So let's see what we have. So what's the diagnosis? What would you want to do for this patient? How do you narrow it down? I think I'll just give you guys a few minutes so I see what ideas you come up. What do you want to do for this patient right now? So remember, she has right lower quadrant abdominal pain. She appears to be in pain. Her blood pressure is a little bit high, maybe a little bit tachycardic, but she's not toxic looking. She's still responding to you. So how do you want to diagnose it? Pregnancy test, ultrasound. What ultrasound are you thinking about? Of course, pregnancy test, definitely. Because all females older than 13 or they're menstruating need a pregnancy test, because you never want to miss a pregnancy. I believe my teenagers, but sometimes it takes a little bit of getting used to them before they can talk to you. Ectopic pregnancy, of course. So you're thinking about an ultrasound. Of course. So Imogen, because it's in the right lower quadrant, you want to think about both ultrasound of the appendix and the pelvis at the same time, and you can get it done. Because if it was a male and you can examine the genital organs and you're not seeing anything differently, the only thing on the right for males is the appendix and intestines. But for females, always think about the uterus and the pelvis and the ovaries. So this is where you actually consider doing both. And CT, especially when the kids end up in adult hospitals, they're more likely to get a CT. But for children, we don't like exposing them to radiation of CT immediately. So we do the ultrasound first. And of course, everything else you guys said, the HCG, which is a pregnancy test, the urinalysis, and the STD. But we will stick to pregnancy at this time. Pelvic, perfect. So kind of gave the answer away already. But this is an ultrasound of this patient, and you can see this mass. And you can see what we call the whirlpool sign of like blood vessels around it. And I would kind of differentiate blood vessels and Doppler flow in ovarian torsion and testicular torsion. So we never miss that. But this patient had ovarian torsion because the ovary is twisted around each other. And this is one emergency you don't want to miss because it's always a matter of time. So let's talk a little bit about ovarian torsion. So this is the uterus, and this is the ovary, and this is like what we call the fallopian tube. And these are all the ligaments that help connect it. So how torsion starts is, it's just like when you have a sack tied and put a stone inside. It starts twisting around each other. So this is what's going on with torsion. You can see because the ligament this is a ligament and this is ovary. If anything makes this ovary to be a little bit bigger than it's supposed to, it starts twisting around each other. And you can see you're twisting off, and as long as it's twisting and cutting off the blood supply, you start having a lot of congestion, a lot of edema, a lot of blood going into it, and it starts becoming bigger. And that's the mass you may palpate or you may touch an examination in ovarian torsion. Appendicitis, you're usually not able to palpate or feel a swollen appendix on exam, but in a patient with appendicitis, they may be what we call peritonitic if the appendix is ruptured. So every time you touch them lightly, they're in excruciating pain, but technically you should not palpate a mass in appendix unless it's ruptured or has formed a ward of abscess. So this is anatomy of ovarian torsion. And ovarian torsion is a rare gynecological emergency. It has to do either when the ovarian ovary or the fallopian tube is twisted on its ligaments. It might be complete, it might be partial. So it affects all females, but actually prepubertal females or females between the ages of 9 to 14 are more affected. And this is because the tissues are a little bit more flexible, so they have a higher chance of twisting around itself. As they get older, they become more adhered, so they may not necessarily twist. And the reasons why they twist is, some say it's unclear, but then the possibility, like I mentioned, is because the ligaments are longer and because they are more lax, they tend to twist around each other. And then also you can have patients, especially I mentioned, this patient has polycystic ovarian syndrome, which means they have a whole lot more cysts in their ovaries. So more cysts, more content in the ovaries become larger, and then they start twisting because now they're much bigger than the ligaments which are holding them together. So think about it that way. And then also tumors, anything that's huge in the ovary makes it more likely to twist around each other. Does that make sense? I hope it does. So how do you diagnose this? So this is one of the scenarios that your history and it's actually very key. So it's one of the things that starts early with abdominal pain, progresses fast. You get the nausea and the vomit, and the patient looks really sick and uncomfortable. It's not like gastroenteritis that they may be answering and saying, okay, does not feel well. It's a true emergency that you need to get pretty fast. So ultrasound is more preferred because it's easier to diagnose than CT and MRI. CT also has a huge radiation exposure, so we don't always want to do that in pediatrics, but they may do it in adults. MRI needs a whole lot of technical protocol. So it's more like a delay. So you never want to wait for an MRI for this patient. And doing an ultrasound. So it's always important to know in the emergency room, when you want to do a pelvic ultrasound, they want the bladder to be full. So just like in pregnancy, because you want the bladder to be full so you can use it as a window channel to see what's behind the bladder, which is the uterus and the ovaries. So you want the bladder to be full. But because you're concerned about ovarian torsion, you don't want this patient to feed too. So these are the instances whereby we actually recommend passing a urethral catheter through the bladder and fill the bladder with saline. Children don't really like this, but if you're concerned enough about the ovary losing its blood supply and use, you always want to do this immediately. So that's why we pass the catheter. And I told you guys I was going to tell you the difference. So if you look at this, it's just a whole lot of blood supply. So this is your ovaries, but the blood supply to the ovary is supplied by two different channels. So you have one coming from the uterine artery, but you also have some coming from the ovarian artery. So if you have this cut off from here, you will still have some blood supply to the ovaries, but not enough to sustain it for a long period of time. But when you do an ultrasound or read an ultrasound and see, oh, I see a mass, but there's blood supply, it's not torsed. No, you can still have torsion and have blood supply to it because you have two different channels. But in testicular torsion on the other side, once you have a torsed testicle, it only has one blood supply. So once you look at the ultrasound, you will notice there's no blood flow, and that kind of gives it away. But don't be deceived by this. So that's why I said normal blood flow in ovarian in the ovary does not rule out torsion because it has two different places supplying this. The sensitivity to ultrasound is also not that good. That's why you need a really good history to help you think about it early enough so you can get that and make sure it's a pediatric radiologist reading it if you have one. Of course, you need your HCG to make sure the patient is also not pregnant. So how do you manage this? And you can start sending your questions and comments now so that we don't get a delay. So management is all about time. Some studies have shown is pain that are going beyond about 10, 12 hours or up to when you start pushing towards 24 hours, and the risk of losing an ovary becomes higher. So this is one of the places that you either stabilizing and consulting at the same time if you know that this patient has a tossed ovary. You may give pain medications, make sure the patient has nothing else to eat. You can try ondansetron, which is Zofran, to help with the vomiting, and like blood work, because if they've been vomiting for a long time now, there's a higher chance of electrolyte abnormality and also low blood sugar. Although in a child that's older, not as much in this child that's younger. Of course, you can give some fluids to stabilize them. And you need to call surgery or gynecology as soon as possible because this patient needs to be in the operating room to get that detours. And what they do in the surgery might be, it depends on how bad it is. It's it might be between detorsing it or taking out part of the fallopian tube or removing the cyst. I never go to the OR for this, so it depends on what they do. But those are the two options. So question and answer. And just to summarize the case, this is a 14-year-old who's coming in with a 12-hour history of abdominal pain, seems pretty uncomfortable with nausea and vomiting, no fevers and no diarrhea. And on the abdomen, you examined, felt a mass, and it was an ovarian torsion. Questions before we go to the last case. If you have a teenage patient that admits to drug use, is there anything you do with the patient after treatment to what their problem was? So there are two different ways you can do this. If they need help or the parent needs help, you can actually get them linked up with social work and a drug program so you can help them. And of course, if they're getting admitted, you can get help. Typically, it's a tricky one because if they're not ready to think about rehab and help, most of the time when you provide that help, they may not necessarily take it. So that's why, but we still discuss this with social work or all our other social departments. So vomiting, when you have an organ twisting, even though it's not where the GI tract is, that twisting motion, it causes what we call writhing pain. So it always needs, you always tend to make them uncomfortable. So even when they're not eating, the writhing pain of twisting makes them keep vomiting. And that's the same thing in testicular torsion too. They feel the pain in the testicle because there's a twisting motion going on, and that keeps making them throw up. Good question. Do you want me to keep going or wait for more questions? Okay. One more second and I can go to the last case. Okay. So our case 4 is is obesity a factor of PCOS or is it genetic? So it's a little bit of both. PCOS has to do with an imbalances of your hormones. So PCOS itself tends to make you become obese because you have more hormones that are making you a little bit bigger. But obesity might be a risk factor too. It's a little bit of a chicken and egg situation, but they tie in end to end. The fat patients, the only way they were diagnosed with PCOS was when they realized they started gaining more weight because the hormones responsible for that, which is making the polycystic ovarian syndrome, is starting to make them obese too. Great question. So our last case is a 7-year-old with a past medical history of asthma who's presenting with worsening abdominal pain and vomiting. And mom brings him in and says he was riding his bicycle, had no helmet on, and he fell. And on his way down, he hit the handlebar. The handlebar hit his belly when he was falling down. So of course, patient with riding a bicycle with no helmet. You want to talk about? So this case is one. Before you even delve in, I want you to think about what do you do first. You go look at the vitals, get a good look at the patient. So this review of system is technically what you're going to ask, but a handlebar injury to the belly sounds more like a trauma, which is, it is a trauma. So you would want to think about stabilization for this patient first before you go asking all these questions. But these are questions you want to ask. There was no helmet, so probably had a head injury. Did the patient lose consciousness? Did they have a chest pain? Did they also hit their chest? Because now you're thinking two systems. Did they pass urine because they hit their belly? Was there any blood on the urine? Any thoughts on this case yet? On what you're going to do, what you think might be going on, what you might see in the vitals? Just keep pouring what you think is going on. I will give you maybe a few seconds to get that ready. Of course. Vomiting might be related to the concussion of hitting his head. Of course. Spleen, good. I like it. Because yes, they might be having a concussion, but so now they're having a mix of two things, the concussion, but also the abdominal pain. Any other thoughts? CT, okay, good. Make sure brain is okay first and foremost, of course. So that's why I said, look at the patient, look at your numbers before you decide on diagnosis and all that, okay? MRI or CT scan. So yes, so I will go through what I want you guys to think about for this patient before we neuro check internal bleeding, definitely. So you want to see what's the status of this patient. Look at the heart rates. Is it too high? Is the patient hypertensive? Because you're thinking about internal bleeding. So you expect the heart rate to be higher, and the blood pressure to start going down for the person I mentioned internal bleeding. What is the capillary refill time? Is it prolonged? Are they losing enough blood to start getting dehydrated? What is this patient's mental status? Because remember, they bumped their head, but then they also fell and they're losing blood if possible. So you want to make sure, what do they look like? Have they peed? Are they that dehydrated that they can't pee? And of course, you're looking at the abdominal exam focally because the main concern was abdominal pain. You're going to look at everything else, but you're trying to figure out what part of the abdomen does the patient hurt more. Is it the right? Are you thinking about the liver or pancreatic injury? Or are you thinking about the left upper quarter where the spleen is? Or maybe in the middle where you have a pancreas too. So you're trying to, in some cases, you might be able to narrow it down. In some others, you may not be, but just kind of gives you an idea of where you should be looking at. So look at the blood pressure. Tell me what you guys think. We're almost coming to the end, but I want you to participate in this, knowing fully well what we've discussed so far. What do you see in the vital signs? Temperature is 99.1. The heart rate is 140, and this is in a 7-year-old. Does that look normal? The patient is breathing at 32, and the blood pressure is 87/40. Check for external swelling on the head, okay? Low blood pressure, perfect. So that's a little bit low. So you're talking about hypotension. A low blood pressure means hypotension, okay? Anything else? Okay, you can continue with the other, keep talking about the blood pressure. Low blood pressure, perfect. So what does the patient look like? He's alert, so which means he's mentally stable, but he's writhing in pain, holding his abdomen. He appears pale. His caprifill is delayed. Caprifill is when you press down and count 2 seconds, you want to see what comes back. Typically, it should be less than 2 or 2 to 3, but this patient is going towards 4. So that means something is wrong. And then on your focal exam, you see this. So this is the left side of the abdomen. So this is the left abdomen. So which means they probably fell more like on the left side. And of course, for the rest of the examination, you're looking at the head because they weren't wearing a helmet, and you're looking for open fractures, bumps, swellings, and everything else. And all of the exams. Remember, this is a patient that you will eventually examine fully, but you're going to narrow it down to the abdomen and the head for now, or more like what we call a quick primary survey, because you're looking for evidence of trauma and things you can do right now before you go down to take a look at everything else. But don't forget, for a patient that fell on the abdomen too, you're worried about the bladder and you're also worried about the genitals. That's why I asked about the urine and the blood in the urine. So it's always a quick survey knowing what you're looking for. So what would you do next? So this is a patient who seems to have an abdominal trauma, possible head trauma, has a low blood pressure and high heart rate already. What comes to mind? What do you want to do? No circulation, perfect. So what do you want to do? Spleen, bleeding, I like it. You guys are so smart. V. Okay, so I like that everyone was mentioning circulation. So this is a patient, first of all, that needs to be in the critical care bay. This is a patient that needs more people getting involved with the care because one, we're talking about circulation involved. In children, we start with circulation and respiratory problems before they go into cardiac arrest. So you're worried about this patient because that's how it slowly starts. So you want to make sure you put in an IV as soon as possible because you want to start getting fluids in. He's losing a lot of blood, like all of you smart people have mentioned. So you want to make sure you're getting this patient hydrated as possible. You can also put in an IO. So IO is essentially a form of, so you can use this as an alternative to IV if you're not able to get any line for this patient, but technically in kids that are much sicker or more unstable. So we know our patient is breathing already, but that's what you always want to consider. Is this patient breathing or not? Is this patient's airway open? Do they need to be intubated? Are they sick enough to need intubation? Do you think they need an NG tube? If they've been vomiting a lot and you think their belly is full NG tube helps you get rid of the things in the belly to give them a little bit of comfort. Do they need a chest tube? So that's what the primary survey of you taking a whole look at the patient briefly tells you. There is an injury to the chest. Do we need to have chest tube because you think may have um, air in the chest or not? Do you need a urinary catheter? So these are the things you want to think about in terms of stabilizing the patient before you get towards imaging. You already know there's something in the belly, but getting the imaging immediately will not solve the problem. You want to stabilize your patient always. And in terms of those that mentioned CT, I mean, X-ray, CT, ultrasound, are all the images you can use to figure this out. But one, always know what's available in your hospital. If you have an X-ray capacity, they can always do bedside X-ray that can show you fluid in the what do they call it? Fluid in the abdomen. But there's also called something called fast ultrasound, which is a bedside ultrasound that can help you look at 4 different areas when you have a patient with belly trauma, chest trauma, because you're looking to see where the fluid is. So that's what you do. So this is one, they're looking at fast ultrasound of the lungs and the heart to see if there's any fluid in it. But for this patient, that's what you want to start with if you have that available. And of course, X-ray, not the most sensitive, but I can also give you an idea of what you can do. It depends on what your facility has. But this is a patient you want to do what we call a portable X-ray for and not send them to the X-ray room because you're worried about this patient crashing. And of course, consult definitely comes in. So this is where you get your surgical team and trauma team involved too, because in the ED, yes, you're stabilizing, you're putting in the tubes, you're making sure the patient is not getting worse, but this child might need to go to the operating room too. So you want to start getting things started too. So prioritizing, but making sure you're not missing out different aspects when you're doing that. So I like all the ideas you guys gave, and I wanted to bring this chart up just to kind of show you where the different structures are. So you have the stomach, the spleen is hiding behind there, and the spleen is actually one of the most ruptured organs in children from blunt trauma based on how they fall. So it's not unusual, and it has a huge, it's well vascularized, so they tend to bleed a lot too. And of course, the liver and the gallbladder, and also the intestines too, you can have that ruptured. And of course, the bladder sits down here, which is why it's important to make sure you ask if the patient has peed or if there's any blood in the urine. So I talked about the fast. So this is what you see in a fast scan. So the spleen and the kidney, so you have the spleen on top and the kidney on the left kidney below. There should be no gap between them. But seeing a gap between them shows there's free fluid, then you have to get a CT immediately. So the fast does not tell you there's no fluid. It just gives you an idea if there's how much fluid or not. Can I delay my CT or not? But that's something you can get bedside. So that's why we always do that first. And this is what we used to call the diagnostic peritoneal lavage. We don't do that anymore. And of course, in terms of labs, when you're putting in the IV initially, you want to think about what are the things you want to collect. So that way, that's getting ready while you're trying to get your patient all stable too. You're getting blood ready, so you're cross-matching blood because they might need transfusion. You want to get a rapid blood glucose. You want to get the liver enzymes, because in as much as you might be thinking only the liver, only the spleen is affected, the liver may be affected too. And technically, in liver injuries, your liver enzyme increase, even if they look normal now, is something you want to trend over time if this patient ends up getting admitted, so you can see if there's any changes going on. The serum amylase and lipase tells you about the pancreas, and the blood lactates kind of gives you an idea of what do they call it? The shock, the hypertension going on in the patient. Of course, urinalysis because you're looking for blood. May do an X-ray second because broken bones and stuff. Good. So you may take a look at the X-rays too, because you have like your ribs around that area too, which may be one of the reasons why the patient has a ruptured spleen, because you may have a broken bone piercing to the spleen too. That's perfect. I like it. So what's the management? So this is very timely too. You need to make sure you're stabilizing and consulting at the same time, kind of what we've gone through already. So you resuscitate the patient, making sure they're not in pain. You can consider IV pain medication at this time. You're consulting your trauma services. And of course, make sure that if you're looking at the spleen and looking at the abdomen, you're not missing a broken bone somewhere else. So when you're done with this patient being stable enough to get all your other imaging, do a full examination, including the neck. Make sure you go back to the head. A patient being alert does not mean there's no fracture or brain bleed. It may be taking a while to present. Make sure you're looking at everything, all other parts of the body. So now your patient is stable. They think they get all the imaging, and all you discover is a splenic injury. Splenic injuries are managed differently. It may mean surgery. It may mean admission because some of them just recover on their own. Maybe it's a small enough bleed that does not require any intervention, just requires hydration and all that. So those are the ones that they admit in-house and keep repeating their CBC to take a look at the hemoglobin levels. And you can go check up the management. But if the hemoglobin levels, the blood level starts dropping, then they may consider what we call surgery, but not all splenic liver injuries require surgery actually. Some of them are admitted, put on IV. If they need blood transfusion, they can consider that. And then of course, always coming back to your disposition, where does your patient go? Do they go to the operating room? Do they go to the pediatric ICU because they're unstable, which may be where this patient might likely go? Or do they go to the floor because they're more stable and just needs observation and decision? Okay, so let's come back. You can start sending in your questions now, but let's come back to this question. What patients would you see first based on all the discussions we've had? Let's see. I mean, you guys have done some amazing job with the questions and everything coming in, but who would you see first now based on all the ones we talked about? And I'm happy to start taking all other questions related to the case, unrelated to the case, now until our time goes off. 4, okay? Does anyone else see someone else differently? Many 4s. Okay, so I think we achieved something today. Yes, definitely number 4, because it seems to be a crasher. It seems to be a patient that might need more. We need to make sure he doesn't tip over to the other side. Questions and questions and questions. These are all the cases I have, and I hope they were useful. And I'll take questions regarding the cases, questions unrelated, questions to medical school. I mean, I'm an international medical graduate, but other questions, I can take them now. And if anyone is interested in pediatrics, emergency medicine, or let me know. And just one quote I want to leave you guys with. I know the journey to get into your path in life may be long, maybe different, maybe traditional, non-traditional. It's always good to take a rest if you get tired, but never give up on chasing your dreams. Just keep chasing that dream. Everything is possible. You just need a little bit time and effort and rest, and just keep going. And this is my Instagram account. You can follow, message me. I can give my email. I just don't want to share my email on YouTube right now. So let me know what questions you guys have. And it's been a pleasure speaking to you guys.
Thank you so much, Dr. Orajiaka. This was wonderful and interesting to learn. We all appreciate you so much.
Everyone, you're so welcome.
Thank you. Everyone, make sure you check her out on her socials. Additionally, the form has now been posted in the comments. Thank you all for attending this morning, and it's about to be in our Instagram bio. So please fill it out within the next 30 minutes for us to receive verification of your attendance. Please
feel any other questions? Okay.
Yeah, please feel free to stick around and ask Dr. Orajiaka some questions. And we'll send the questions in the chat box.
Okay, I'll just look for it. I still have a few minutes to hang out, so I know we kind of went beyond time.
No worries. Thank you.
You're welcome. Can you touch on the emotional toll that working in pediatrics can have, and how you deal with that, especially working with kids and worried parents? Okay, so this is not something you learn. It's something you kind of learn over time. But one, if you have a family of kids, one, you have to know how do you handle stress first for yourself, because over time you start taking emotional toll on you. So you have to have a strategy for self-care. Make sure there are other things you enjoy outside of medicine. Make sure that ways you kind of get yourself back after you've had a rough day. And with regards to worried parents, I guess for me, what has worked for me is I realized that one, the parents are not coming in aggressive towards you. They're honestly worried about their child. So you have to find a way to, one, understand what their concerns are. Two, you want to have a way of explaining to them, especially with pictures. I do a lot of pictures, as you guys can notice. Show them what, so maybe they're worried about the belly pain, which might be constipation. Show them why appendicitis is not a possibility. Show them why this is not a possibility. So a lot of education and time taking sometimes helps with these patients if you think there's nothing wrong. If there's something wrong too, you may go to an extent to appeasing them and calming them down, but in some scenarios, you may get the social work involved with it because sometimes it may get too time consuming that you may not have the time to take a look at other patients. So in terms of the patients, try as much as you can, use pictures and get social work involved. For yourself, over time, you have to have some self-care that you always do and make sure you know that some of these things are not personal. It's just a worried patient trying to say what they want to say to you, and they may not necessarily mean to be aggressive. That's what I've been taking it now. What are strategies for dealing with nonverbal patients? So for nonverbal patients, they tend to be more anxious every time you walk in the room. So make sure that you are getting their point of view first. What does that mean? When you walk in the room, don't touch the patient. I usually just stand at the door, see how the patient is interacting with the family, see how much discomfort they're in. If I go into the room and the child is playing and happy, and when I get close, they start crying, that means it may be more of anxiety towards me than being in pain. So that's what I do. I do a lot of observation first. And then I talk to family and see what their challenges are first and know where to go from. And then common things are more common. Like if I think a mom is like, the child hasn't stood yet for a while, I might think maybe constipation, has been crying excessively, maybe it's related to the throat. And it also depends on what illnesses are going on around the other time. If is strep throat, is it a strep throat season? Some of them come in crying a lot because they can't tell you their throat hurts. But again, those are the patients that I tend to do a whole lot more evaluation for, because I just can't figure it out. So if I've done my part of being able to examine from the door and I still can't do it, then I do more testing just to kind of know how to help them. How did the amount and type of patients change over time? So in terms of type, now we're seeing much sicker kids, which is what emergency medicine is actually supposed to be. Because pre-COVID, we would have a whole lot more kids that come in who don't have anything done, and parents just want to make sure they're doing fine, and they would have been able to wait to see their regular physician. But now with COVID and people not being very comfortable coming with the hospital, one, we're seeing children that actually need to be seen. But on the flip side, we're also seeing children who are so much sicker and who have taken a long time to present to the ED. So maybe we're seeing a patient who has diabetes going into DKA, and they didn't come in early, so they're having like mental status changes before they come. So there's just a lot of pros and cons, and we're obviously seeing less numbers now, but then they are much more sicker patients. If a child or patient and their family disagree with medical decision forwards, whose decision do you honor? Is it oh, I'm confused. Oh, if a patient and the parents. So when you talk about patient, it has to be, so it depends on how I'm worried about this patient. If I think this patient needs a CT or maybe needs more evaluation, because not every child likes an IV. But if I think you need an IV because I think you're sick enough and I think something might happen when you leave the hospital, I would probably favor whoever is more in line with what I want to do than allowing them to make that decision. But if it's a child I think looks comfortable, but the parent thinks they need an ultrasound or imaging that's not related, I don't necessarily have to do it, because one, I think the child doesn't need it, and then two, the teenager is in line with what I think. So I try to convince the family they don't need it. Do you see more high acuity patients at the pediatric ED physicians? So when you say I see more high acuity compared to every pediatrician in the clinic, but in my institution, because I have a pediatric emergency medicine fellowship in it, the PEM attendants always see high acuity than I do. So I can see like these trauma cases, but if a patient needing like a lot of intubation and all that, I may not necessarily see them because we have PEM trained doctors in my facility. How is the mental state of the workers in the working in the ED? So it definitely varies by how you're able to manage your mental state outside the hospital or outside the ED, but it can get pretty overwhelming. And it also depends on the days. Some days we are laden with a lot of traumas, child abuse, sexual abuse, and it definitely gets depressing that you may take some days off to just kind of renavigate and remember your why and remember why you're doing this to help. But it can definitely take a toll on you. Always remember to talk to people. Some people try therapy, some people speak to family members, but always do things that help you maintain your mental state. What do you do in a case that the patient and guardian have different opinions? Yeah, I think someone else kind of asked me that. I decide to do what's best for the patient if I think they really need evaluation done. And if I think they have different opinions, I try to bring them to the same page if I think it's going to help them. Okay? I think that's about the questions we have today. And feel free to, what do they call it? Ask me any questions on Instagram and I can always find that out. Do you have any other questions?
Thank you so much, Dr. Orajiaka. We really enjoyed your presentation and it was super interactive.
Yes,
Thank you.
so much.
It was
Okay.
a pleasure having you today.
Everyone loves you.
Thank you. Love you guys too. Good luck and keep going. And I'm always here. Just feel free to text me or let me know what you need. All right. Thanks. Bye. Great job, WebShadowers. I can always come back again for a different topic, maybe in October or November.
We
Yes,
would love to have you again. We'll stay in
Okay.
contact.
Okay. Sounds good then. Take care. Okay. Bye.
Take care.
Bye. You